Typically, we'll have the patient with their knee off the table, so it's nice and relaxed. We want their ankle to be in a relaxed position, okay? Most people, when their ankle does become relaxed, it'll be a slightly plantar flex position. That's what we want, a slightly plantar flex position. And what we're going to try to do is a drawer technique, where we're going to pretend that the talus and the calcaneus are a drawer, like a Chesterfield or a bureau. We're going to slide the drawer out. So we're going to slide the calcaneus and the talus out, and by doing that, we are going to be stretching the anterior talofibular ligament. That makes sense? Because it's going to be attaching to the talus, so if I pull the talus anteriorly, that ligament's going to stretch. So obviously, if there is any disruption in that ligament, what is that? Is there something like... Okay, whatever. So that ligament will potentially stretch. And obviously, if it's already injured, if we try to put any more stress through it, it's going to fire them up. Anytime you do a ligamentous stress test, we're looking for a couple things. One is pain, and two is what we call the end feel. The end feel. Ligaments should give a nice, like a leathery end feel. It should give a little bit, but it should come back. That's the ligament kind of stretching and then snapping it back in place. All right? What we don't want to see is what we call the empty end feel, where it's just, whoop, gone, and you get that sick pit in your stomach because you know the ligament is gone. There's also something called the sloppy end feel, where you kind of feel it, but it's not taut, it's kind of sloppy. Very scientific way of saying it. All right, so the way I do my drawer, use either hand, it really doesn't matter. Stabilize the tib fib. I cup the calcaneus and the talus, and the technique is that I'm gliding this way. Don't rotate and pull up. We're not looking for that. We're trying to literally glide the calcaneus anteriorly. Does that make sense? And the talus will go with it. Okay, so that's the anterior drawer. Looking for any pain, any laxity. I can see it gapping a little bit. Does that hurt? And because I do it on this side, what do I automatically have to do? Do it on the other side, always comparing bilaterally. All right, so that is anterior drawer. It is your staple ankle test. You've probably seen it done a million times. All right, matter of fact, I bet if we do it on your patients right now, they probably all have some sort of degree of laxity in there. All right, so the next one's going to be the medial and the lateral tower tilts. Medial and lateral tower tilts is just basically an inversion and an eversion moment. Now for this one, I can actually slide it back a little bit. And I like to put them in 90 degrees because I'm just trying to tilt the talus. I'm not moving calcaneus. So I like to kind of put them here. I'll stabilize and I'll just sort of tilt. You're not going to have nearly the same amount of motion as you will with the anterior drawer. Same thing for the eversion side, right? So I'm just trying to go, and I'm trying to stretch those ligaments. So the eversion tower tilt is going to be for my deltoid, and my inversion tower tilt is going to be more for my calcaneofibular ligament. Everyone can kind of see how that mechanism would work. Anterior drawer typically is for the anterior talofibular ligament. Okay? Questions? You guys want to practice those three?